Hi, it's Ben Carden, once again on Facebook Live, a program that I do every so often to bring the people of Maryland in our conversation on lively subjects that are taking place in our nation's capital. Today on Facebook Live, we're going to talk about prescription drugs and the cost of prescription drugs, which has been escalating at an incredibly high rate for a considerable period of time, where the cost of prescription medicines are far exceeding the cost increases of inflation, and where we've seen more and more reliance upon the needs for prescription medicines. It's causing a major problem for American families to be able to afford to take their medicines. So we're going to talk about that situation today and what Congress is looking to do about it and what is an effective way for us to deal with the rising prescription drug costs. I'm pleased I have three real experts on the subject to join in this conversation. Dr. Onukwugha is from the University of Maryland School of Pharmacy. So we have the University of Maryland represented. Dr. Socal is with the Johns Hopkins School of Public Health at Bloomberg School at Johns Hopkins for School of Public Health. So we have both Johns Hopkins and University of Maryland represented in regards to public health issues, both, of course, institutions that lead our nation in dealing with public health issues. And then our third guest is a person I know very well. I served with Jim Campbell in the Maryland House of Delegates. We both represented the same district, and we are colleagues and friends. Jim is now the president of the AARP Maryland Chapter and is representing the consumer interest in what we can do in regards to prescription drugs. To start the conversation, let me just ask all three of you, how important is it for individuals to have access to prescription medicines? And how well are we doing on making sure that we have access to the latest medicines available to all of our population? I'll start with Dr. Onukwugha. You're directly involved. You may want to talk a little bit about your responsibilities in School of Pharmacy at the University of Maryland. I've been there before. I know it's an incredible institution. And just tell us generally how we see the current situation.
Thank you very much, Senator Carden. It's great to be here. Pleased and look forward to the conversation this afternoon. My name is Ebere Onukwugha, as you mentioned. I'm an associate professor at the University of Maryland School of Pharmacy. I am located in the Pharmaceutical Health Services Research Department. I also serve as Executive Director for Pharmaceutical Research Computing, which is a data computing unit within our department. My background is in economics, and much of my research examines healthcare utilization, particularly race disparities in access and the burden of illness. This is an important topic, and couldn't stress more the importance of addressing it because solutions are yet lacking. In 2020, I was pleased to participate in several community forums hosted by the Maryland Healthcare for All Coalition. And with those forums, was able to talk with Marylanders across the state and learn more about their experiences with the burden of paying for prescription medications, trading off costs where they are forced to address other survival needs, even though they also need access to their medications. And the stories that I was hearing resonated with me because it's also consistent with what we know in the literature about individuals' inability to afford medications and to stay adherent to prescribed medication regimens, all due to the cost of medications. And we also know that there are race disparities in how this economic burden impacts families and households. So this is absolutely an important topic, and I look forward to our conversation.
Well, thank you. Dr. Socal, the Bloomberg School of Public Health is known globally for its commitment and training of individuals in the public health field. Tell us a little bit about your position there and how important it is for us to have access to prescription medicines fairly in our community. I think you might be on mute.
Thank you so much for having this conversation, and thank you so much for having me today. I'm a physician by training. I have a PhD here from Johns Hopkins in health systems. And most of the work that I do and teach here is around the US pharmaceutical market. And I would say that the number one reason why we should be even talking about this today and why affordability of drugs is so important, it's because for many people, there's just no other choice. Drugs have become a lifeline for several conditions. And we all, as patients, as people who have, a variety of health issues, we can even have drugs that save our lives, they improve our quality of life, and even oftentimes prevent problems in our life. So for many people, and today, we always think about persons, for example, with diabetes or with asthma or with cancer. All of these individuals, having access to a drugs makes a real difference. And oftentimes is a very short time frame difference between life and death. And also sometimes it's even better for people to go without a drug than to go on a drug intermittently, be able to afford a certain drug today and not tomorrow. So these are choices that unfortunately people have been facing every single day in this nation. And with real life-saving drugs like insulin and other things, that patients really don't have another option, and they don't have a negotiating power, and they really need our help. We as a society, we need to address this problem.
Dr. Socal, I think you raised such an important point. I could tell you that we have heard from constituents in Maryland about rationing their use of prescription medicines because they literally cannot afford the cost to refill their prescriptions and have it available in the usage that was prescribed by their physician. They have to choose. So they'll cut back on the number of times they take their medicines. And as you point out, in some cases, that can be more dangerous than anything else. But the reality is that people cannot afford to take all the medicines that they need to take in order to prevent illness and to treat different types of diseases. So it is an immediate issue. It is an affordability issue, and it is a health issue, as you point out. And it does affect particularly our most vulnerable community the most, including our elderly. So, Jim, I think we all know AARP, but we know that they focus on issues that affect people as they get older in life. So tell us a little bit about how you see this in your position as president of the AARP Maryland.
Yes. Senator, thank you for this opportunity. We really, really appreciate it to talk about one of the most important topics for Maryland seniors, the high cost of prescription drugs. I know you've been a leader on this issue for many, many years. And from just the discussion so far, I'm really happy I'm part of this panel to raise the issues that really need to be raised for our seniors. AARP has 900,000 members across the state, and the escalating cost of medicine, one of the most important issues affecting their daily lives. We constantly hear from members how they struggle to make ends meet by having to balance housing costs, utility and bills, and food with their healthcare costs. The problem is even worse now because of high inflation. It's distressing to hear people who have kept to cut back on their medicines to make ends meet. And one of our members I'm going to use one of our members as an example, and he's been on some actually ads for AARP. He's a retired state trooper who developed Parkinson's disease several years ago, and his monthly expenditures for medications amount now to $3,000. He recently had to sell his home and take other drastic measures such as cash in his investment savings to make ends meet. And this is just one of probably many stories out there. For years, prescription drug increases have dwarfed even the rates of inflation. If consumer prices had risen as fast as drug prices over the last 15 years, a gallon of gas would cost $15 and a gallon of milk would cost $30. So we're really concerned about this issue. I'm glad you're raising it today, and we're looking forward to this discussion. Thank you.
Well, thank you, Jim. I appreciate those comments. Let me make a couple observations. With the University of Maryland, Johns Hopkins, you have two of the great academic centers in the world located here in our region. The United States is known to have the best medical institutions in the world. We frequently will get visitors from other countries that will come into our region to use our facilities because they know it's the best in the world. At NIH, we have the best research capacity in the world, the National Institutes of Health. And we invest substantial resources, public resources, into research. Drug development in the United States is the best in the world. We have our technology, our scientists, our researchers have been able to develop the medicines and the biomedicines that have kept us healthy. So we have the technology here. We have the workforce here. We have the institutions here. But the United States is an outlier in regards to drug cost. No other country in the world pays anywhere near what we pay for the same medicines that are manufactured right here in the United States. Why is that true? Why is the United States an outlier when it comes to the price of medicines? We all know the stories of people going across the border in order to buy their drugs because they're cheaper. Same medicines manufactured here. Why is the United States so much more expensive than other countries on the cost of medicines? Dr. Onukwugha, I don't know if you want to tackle that one, but let me start with you, and I'll give every one of you an opportunity to give your reasons as to why you think we pay so much more for drugs.
Thank you, Senator. And the comparisons you gave have been well documented in the literature about the out-of-pocket costs that Americans pay compared to other countries, and disparities in that out-of-pocket cost as well, I think are under-researched and underappreciated. So I can't emphasize enough the fact that while the average is higher, there are subpopulations that shoulder an even larger burden. And the reasons many have mentioned in prior work, in prior discussions, have a lot to do with regulation, the way our insurance markets are set up, whether or not we have a single payer. We do have one for our over 65 population and individuals who are otherwise qualified for Medicare. But unlike Europe, Australia, and many countries, we don't have that national body that reviews the evidence that determines access, effectively also setting access for individuals. And that has been hotly debated as far as the pros and cons of moving to that type of system. And we've seen how NICE in Europe has worked through some of those pricing and access concerns, some of which you've mentioned in terms of individuals traveling for access to technologies. So yes, we have higher prices. We faced higher prices over time. We have disparate burden in terms of these higher prices, a lot of which can be linked to the way our healthcare system is set up as compared to other countries.
Dr. Socal, I have studied the way that we price pharmaceutical products here in the United States with the different levels of participation. And I must tell you, I've been involved in healthcare policy in the legislature since my days in the General Assembly. I dare say I don't think most people can figure out how the pricing is done on prescription medicines. What is your explanation as to why we pay so much?
Thank you so much, Senator Cardin, for mentioning this. And I agree, I teach a class on this for our Hopkins students, and they're very brilliant people, but oftentimes I see their puzzled faces when we talk about setting up drug prices in the United States. I think everybody expects to have a model and to hear how is the model of drug pricing in the United States? And the truth is that we have a market-based model. So in other words, pharmaceutical manufacturers will set the prices that the market can bear. And that's pretty much the summary of it. What I think it's very important that we mention is that when the pharmaceutical manufacturer releases a new drug into the US healthcare system, into the US market, yes, they tend to charge us more than other places because we don't have these evidence reviews and other mechanisms to change the price as when the drug launches. But that's not the moment where the drugs cost too much more to us as compared to other countries. What really, the kinds of drugs and the moments that we're really paying many times more than other countries, if it's for older drugs and drugs that have been in the market for a long time, like insulin. For these drugs, everywhere else, in every single other industrialized country in the world, once the drug is out in the market, their price only goes down over time because there's competition, because there's other mechanisms to lower prices. Whereas here, drug prices for these older drugs just go up over time. And so that's a real challenge for us, is why are we paying so much for drugs that, they're not innovative anymore? They've just been the same drug for years and years, and just keep increasing our prices because our markets bear that.
So to Jim Campbell, you know that we depend upon the market for how our economy works. So why isn't the free market bringing down particularly older drugs?
Well, I'm not sure it's a free market as such. I think a lot of our industries operate on a free market basis, but I don't think drug pricing does. In January, I was looking at some statistics. The drug industry raised the prices on 800 prescription medications just because they could. And as I mentioned earlier, the increase in the drug cost is almost double what other consumer prices went for the last 15 years. So there's really no controls over what needs to be looked at and taken. I think there's a bill in Congress that we're supporting and think is really going to help balance the playing field a little bit. So I'm hoping to get into a larger discussion about that bill and its effects. But I think the industry can do it. It's for many people, it's a life or death situation. I mentioned our volunteer before who has Parkinson's, and he doesn't have other options. And some of these specialty drugs are very expensive, but they're life-saving. So it's something we really need to take a look at. And I think Congress has legislation there to help with us, but hopefully we can get it to pass.
We're going to go over the specific legislation that we're looking at. The bill that you were referring to, it was really the basis of which was developed in a bipartisan way with the leadership of Senator Wyden and Senator Grassley. Senator Wyden, a Democrat from Oregon who currently chairs the Senate Finance Committee, and Senator Grassley, a Republican who was the chairman of the committee previously when the Republicans had the majority in the Senate. So what we're looking at is the basis of their bill. We've built on that, and included in President Biden's program for rebuilding America, we have provisions in there to deal with prescription drug costs that has been scored to save the taxpayers in this country, close to $300 billion over 10 years. That's how much we are overpaying, that we believe, as taxpayers. In addition to, of course, the out-of-pocket costs for the users of drugs that we bring down substantially under our legislation. So let me first pose the dilemma that we have. I was an economics major in college. And I always remember Economics 101. It's a great course. And the supply and demand, that if you have market forces respond to supply and demand. And when you are a big consumer of a particular volume product, you can bring the price down. As we know, you go to your Sam's Clubs or Costco's, and you know what they can do with pricing because they can demand a large market share of a particular product. And therefore, they can negotiate from a very strong position to get the very, very best price on the products that they sell. So the larger you have of a market share for consumers, the lower you can bring the price of the goods to the consumers that you sell to. So who is the largest? Here's a question for you. Who is the largest payer of prescription drugs in the world? Who has the largest market share? So if you're a manufacturer of drugs, you're Pfizer, and you want to get your drug into the maximum number of homes, who is your largest single customer?
Medicare.
Medicare, well, as you go even broader than that. Dr. Socal?
The US, I mean, we're standing
Yes.
alone. We represent 40%. We're bigger than every single other, the next 3-5 markets combined. We are standing really alone in the world in the size of our pharmaceutical market.
You're exactly right. We are by far, the federal government is by far the largest payer of healthcare services in the world and the largest payer of prescription drugs in the world by far. So you would think that market share could bring down costs. Now, there's one agency that spends a lot of money on prescription drugs and has been able to get a much better competitive price than the other federal components on paying prescription drugs. And that's the Veterans Administration. They've been able to pull together their entire buying power in negotiations and have brought the price of prescription drugs for our veterans down below what others pay for medicines. But as Jim Campbell pointed out, the largest single program is Medicare, for good reason, because there's a simple fact. As we get older in life, our bodies become more complicated and we take more medicines. So, and the medicines, as Dr. Socal pointed out, are not necessarily get less expensive as they get, or they're being utilized. So, a typical senior today may be on 4, 5, 6, 7, 10 prescription medicines. So Medicare is the largest payer in the world. But when that was passed, and I might just tell you I voted against this bill and the provisions, there was a provision put in the bill that prevents Medicare from negotiating price with the drug manufacturers. I think most Americans would be very surprised to know that. We don't tell Costco they can't negotiate price with their suppliers. Why would we tell the Medicare that they can't negotiate price? Does any one of you think there's just, let me give you the reason that was given at the time. And that is, we don't want to stop innovation in America. Now, I'm going to give any one of you, or either all three of you, a chance to respond to that if you want. The argument is that if we put any restrictions on what the pharmaceutical manufacturers can price their drugs at, that would stifle innovation in America. So we have to let them sort of have free rein as to how they charge and not organize the market so that the market can have a competitive position in negotiating the price with the manufacturers. Your response to that? Jump in, whoever wants to.
Well, my response would be other countries, Veterans Administration, all can negotiate prices, and things seem to be doing well there. I guess for us, this is a long-standing and overwhelming bipartisan support for allowing Medicare to negotiate with drug companies. Everybody thinks it makes sense, and especially for our members to have the opportunity for lower drug costs. That it's just crucial to us. The proposed policies in front of the Senate right now include, price negotiation, capping costs, and penalizing drug companies that increase their prices faster than inflation. The innovation, I don't think, will ever be a problem. I think the profits are good. These policies, though, that Senate's considering will reduce drug prices and out-of-pocket costs. It's really important for our seniors that we do something now, because the situation is really, with drug costs, is really out of hand, I think. Thank you.
Dr. Socal, I saw that you wanted to.
I wanted to clarify a misconception there, Senator, because I think, I agree with you that many people would just be surprised by this, and they would also be surprised to hear that it's not that nobody's negotiating prices in the Medicare space. When Medicare created the Part D program to have drugs for outpatient use for pharmacy benefit for the senior population, Medicare implemented prescription drug plans that would then negotiate prices on the behalf of the beneficiaries. What is happening is that these drug plans are not doing a good job because, number one, they fragment this huge market, like you were saying. And number two, in many cases, they have been restricting choices for individuals without really bringing prices down for the Medicare beneficiary. And we don't know. We know they do negotiate some prices, but these prices are not transparent. Nobody knows what's the final price that is paid by these prescription drug plans because these are confidential. These negotiations of rebates and discounts, they are secrets. And so having the secretary negotiate on behalf of everyone would stop this fragmentation that we have, hundreds of prescription drug plans negotiating at the same time with the same manufacturers for the same drugs, when we could have just the secretary negotiate for everyone for that drug. And in addition to that, the price would become transparent because then we would know how much was the negotiated price. Oh, it's $100. Well, everybody now knows it's $100. Whereas under the current system, we just don't know. We don't know what's the final price of the drugs that we're paying for.
Dr. Onukwugha?
Yeah, and I would say that I agree with all the points that have been raised so far. And thinking about policy, a lot of times we make policy or we accept policies looking in the rearview mirror versus thinking about what's coming ahead. So as I hear arguments around, price regulation stifles innovation, well, we have to look at the innovation market. How is that evolving? We know NIH is a routine and established funder of innovation. We also know academic institutions are part of that. We know that larger pharmaceutical companies are part of that. With a recent pandemic, we've seen examples of small companies, small private companies partnering with academic institutions and NIH being part of that evidence generation and innovation. Well, is that going to be the model going forward? And how does that then inform our predictions around what happens with prices? So I think a bit of it is really just paying attention to what are the trends coming as we look ahead as to how will innovation continue? Is it going to be the prior model of where it's larger established companies, or is it going to be more your startups and smaller companies in partnership so that our models and our assumptions, I should say, are better informed by evidence? And I absolutely agree with the points around understanding the decisions and the transparent information that we need to better understand how, if I squeeze the balloon over here, what happens over here? A lot of times we lack just understanding of the fundamental structure to be able to draw predictions that I think are reliable. And so we rely on the past information, maybe even rely on uncertainty to guide, and then with that, maybe act too conservatively.
I think you've raised some very, very important points. You're on innovation, on government-funded research, and on the fragmentation of the negotiations. It's very clear that under the current circumstances, we don't have a consolidated negotiating platform. We also use the pharmaceutical benefit managers, and maybe we'll have a chance to talk about that. And they're the middle person who negotiates. So there's not direct negotiations. And their pricing includes discounts that at times puts the consumer at a disadvantage because the payment on the copay is based upon the full cost of the medicine, whereas the plan is only paying a discounted rate. So the plan gets the advantage of the lower rate, but the consumer has to pay the cost on the higher amount, which is, again, counterintuitive, but that's how the pricing mechanism has worked. So the pharmaceutical benefit managers can make a larger amount of money. That's their business, is to make money, and they can make more money, and they do make a lot of money. There's a concentration within the pharmaceutical benefit managers. We only have a few in the whole country, They have most of the business, and they're doing extremely well from the point of view of profits. So as are the pharmaceutical manufacturers, are also doing very well on profits. And the person who's getting hurt, two people, the consumers and the taxpayers, because we don't have the consolidated ability to negotiate price. I want to continue on the subject, but first let me just take a short break just to introduce our guests for those who may be joining Facebook Live a little bit later. Dr. Onukwugha, who is from the University of Maryland School of Pharmacy. We appreciate very much that she's with us. Dr. Socal, who is with the Johns Hopkins Bloomberg School of Public Health, and Jim Campbell, former member of the House of Delegates and now who is president of the AARP Maryland Chapter. Our conversations are on prescription drugs, and we've been talking first on the issue of negotiating price. I say that because in response to Jim Campbell's point, there is legislation pending in the United States that has already passed the House of Representatives, that's in the United States Senate. I'm going to talk about several provisions that are in that legislation. One provision is to allow Medicare to negotiate price collectively through the Secretary of Health that Dr. Socal was referring to in the fragmented approach. That's one of the provisions that's in that legislation that will allow for direct negotiations. But I want to come back to the point I raised initially. The major argument against this, which I disagree with, but I want to put out there, is that by having Medicare negotiate the price, we are putting in effect pressure that will bring down the cost of prescription medicines and therefore make it less advantageous to invest in new innovative research for the new drugs coming onto the market. I disagree with that, but that's the argument that's been made. So I want to at least put out on the table, because I have two academic experts that are here. I'm not going to despair Jim Campbell or me as far as being academic experts. The fact that a great deal of research is done at your institutions, and you partner with the government. There is, as last count, I think, $40 billion of taxpayer-supported research done at the National Institutes of Health in partnership with our academic centers that provide the basic research for the innovation of new drugs in this country, not from the point of view of the amount invested privately. That's what they get the advantage of. And then secondly, the last time I checked, the pharmaceutical industry was spending more on advertising than they were on research. So it sort of belies the point as to if we have a fair price on their product, it would somehow interfere with new drugs coming on the market. Any comments?
What I always like to tell my students when we're having classes about this is that there's just one entity that sets the drug price in the United States, and that entity is the drug manufacturer. It does not matter how much went into the development and discovery of that drug and that how much came from the taxpayer pockets. When the finalized product is there and it's out on the market, it is the decision of the drug manufacturer how much that product will cost. And make no mistake, I fully agree with you. We taxpayers, we fund so much of the drug development in this country. There's many estimates that show that every single drug released in the last decade has benefited from NIH taxpayer dollars in their discovery or in the discovery of their mechanism of action or the proteins that connect with that drug and things like that. So every single drug that has been developed recently has benefited from our public investment in these drugs. Yet, it is a decision that happens at the manufacturer level as to how much this drug will cost. And of course, we academics have not access to what goes into necessarily the decisions of these pricing mechanisms. But several investigations, including from the Senate Finance Committee, have had access to these documents and have shown very clearly that pricing decisions really favor profit over patients. You know, for example, life-saving drugs like hepatitis C treatments, they cure people and they really avoid very severe consequences from hepatitis C. But the drug manufacturer, when deciding how much they will charge for their drug, decided for a pricing point that they knew was going to restrict access to many people who would need that drug. So we do have these incentives built in our system. And I would just add that not only the moment that the drug goes into the market, but the years on, you know, when the manufacturer tries to keep every single competitor away from the market and keep the possibility of having prices so high, because we need the competition in the system to be able to lower prices. So we have these incentives, and that's why we are in this situation right now.
The points that you, please
add to that is, you know, as we worry and think about what happens with future innovation, we have current innovation that's inaccessible to a large swath of the population, where it's not even something that they can talk about as having access to the latest and the greatest oncology drug or drug for MS. And I feel like that is something that is a public responsibility, a shared responsibility among all the stakeholders that we've mentioned just now, who are invested in the future, to also be invested in this equal access among vulnerable populations. And as I talked briefly about before, we also need to better understand the mechanisms of innovation looking ahead, because the pandemic has certainly shifted the need for speed in terms of evidence and the way in which technology happens. The partnerships that are happening, I think, will shape the future. And so thinking about sort of the old world style of the way drugs were brought to market and who owns innovation and who's responsible for R&D, I think that needs to be revisited as well.
Dr. Onukwugha, your point you raised is so important. When the pricing is out of whack, as it is today, the innovation incentives will not benefit those who cannot get access to the drugs. And we clearly have a challenge in America in the traditionally underserved communities for these innovative drugs being available because of the cost issues. So there is clearly a social justice issue here in regards to the pricing that's affecting Americans differently. But I would also argue it's affecting our entire country, because as drug prices are out of whack, it impacts our ability to provide health care to our country, because it denies us the ability to put the resources where they need to be in order to keep our population healthy. So it not only affects the traditionally underserved community because of the historic systemic challenges that we have, but it also affects our entire country. We need to get this right. Prescription medicines are the fastest growing cost center in healthcare today. So maybe when it was just a few percentage of the total cost of healthcare, we didn't have to worry about it being out of step. But now that it is the largest single growth sector, becoming larger and larger every day, not only the prescription medicines individuals buy, but the institutional use of prescription medicines are becoming more and more expensive and are crowding out other aspects of providing health care to the people of this country. So your point is so well taken. I want to get to a second proposal. First proposal, negotiated price, Medicare, and for the federal taxpayer. That will save billions and billions of dollars for the taxpayer and for the consumers. But Dr. Socal, you mentioned the difference between a launch drug, a drug that's coming into the market, and one that's been on the market for a period of time. And you made an observation that we know is absolutely accurate, that drugs that have been on the market, that are well understood and the cost of production well understood, no additional research necessary, those drugs are growing in cost by leaps and bounds, far in excess of the cost of producing the medicine. So one of the proposals is to have an inflation rebate. So if a manufacturer increases an existing drug already developed faster than the growth of inflation, the cost of that would be rebated to the taxpayer or user so that we hold the cost effectively to the growth cost of inflation. That's aimed directly at the point that you raised, and I would welcome your observations as to how effective you think that might be.
I think that would be very important. My own research, we have compared drug prices paid here with prices paid in other countries. We saw that every additional year that the drug is in our market and in other countries, the difference is 30% greater. So every single year that the drugs are existing in our market, we are paying more than everybody else, and we're paying more than everybody else. There's a series of reasons for that, and mostly to do with competition, because where we do have competition, and this is something that we should have, that I actually should have mentioned before, is we have generics, for example. We have places in our market that are good success stories. But the problem is that for certain drugs, they don't have competition, and they have been successful in preventing that competition from happening in the first place. So for these drugs, having an inflationary rebate, because these drugs are old, they're not developing any new additional technology, they're the same exact product sitting there in the market. And they really, like you just mentioned, they don't cost that much to produce. Each additional unit of that drug will really cost, the costs are negligible. So to prevent these price increases over time, it's very important that we have this type of mechanism, and it does exist elsewhere as well.
Dr. Onukwugha, there's also a proposal to limit the costs of some specific drugs that we know are outrageously priced today, far in excess of their manufacturing costs, which are absolutely essential to keep people healthy. The best example of this is insulin. We know how much it costs for insulin, and yet the cost to most consumers are 10, 20, 30 times the cost of producing the drug itself. Economists tell us that it shouldn't cost more than $35 a month for the cost of supplying insulin today. So in our proposals, we put a cap on this drug at $35 a month in order to make sure that we deal with the issue that you raised, that individuals who need insulin to stay healthy, to stay alive, literally, are not going to be outpriced through the marketplace, and yet will still allow a fair return from the manufacturer. We think this answers one of the questions that you raised about being concerned about social justice. Your thoughts?
I think it absolutely does address one important aspect of what we already know regarding the impact of what I'll call cost-related medication non-adherence. And this is when people are splitting doses, missing doses, not filling prescriptions due to cost. That burden has been estimated at 12% to 20%, so upwards of 1 in 5. And we know it can be higher in some populations. So there are a couple of ways we can address that when we see this rising prevalence and this disparate burden of cost-related medication non-adherence. We work on the price end to bring down the prices, and this is the example, Senator, that you have raised. We work on the consumer end to increase their financial well-being, provide them better access to support programs and things of the like. And what I would argue is that the problem will need a multifaceted response, at least in the short term, that individuals right now face those burdens. And the question always that I get asked is, well, what can I do today? It takes a while for evidence to move through and be produced. Policymaking can take time, as we know, and individuals are hungry right now for some of these relief models. And so I feel like that's an important conversation to have as well, is how do we get individuals plugged into the resources that are available for them? And keeping in mind, again, that this is a multifaceted problem. Studies have examined why are individuals experiencing cost-related medication non-adherence. They talk about the price of medications. Low income is another factor that has been identified. An interesting study looked at individuals who are over 65 diagnosed with diabetes and cost-related non-adherence. In that situation, they linked that to comorbid conditions where they have multiple meds that are causing increasing and probably exponentially increasing cost burden on them. They talked about certain mental health characteristics where certain factors that we already know are associated with non-adherence, like depression. How do we ensure that all these, what I would call multifaceted and quite complex conditions get attention while supporting individuals' need to have access?
The points you're raising may lend itself to another Facebook Live show because you're raising so many factors that we are working on. I really do applaud President Biden for the focus on dealing with social justice issues. Yes, we can talk about pharmaceutical pricing, but if we don't talk about access, then the price itself will not solve the problems of the historic systemic challenges that we've had in America, and particularly in underserved and minority communities. So I agree with you completely, and this is an area that we are focusing in on prescription drugs, but we are going to do it on a broader basis on so many other issues in our country. I chair the Small Business Committee, and I tell you, we have been laser focused on helping the traditionally underserved communities and dealing with entrepreneurship, which can lower the wealth gap in this country. Jim Campbell, I want to get back to one more recommendation. We've talked about negotiated price. We talked about inflation rebates. We talked about specific drugs. That's all in our proposals that are pending in the Senate. There's also another dealing with out-of-pocket costs, which AARP has been laser focused on dealing with the cost to consumers, particularly in Medicare under Part D. And that is when the program was created, we had the big donut hole. We all know about that donut hole. We've done things to try to close the donut hole, but there's still a substantial burden on Medicare enrollees on out-of-pocket costs. Those who have the greatest needs are finding it challenging to be able to afford their medicines, even with Medicare Part D coverage. So our proposal would cap the out-of-pocket cost to $2,000 a year. Now, quite frankly, I think that's high, but at least that gives us a level that we know that you're protected beyond that point for those who really do need expensive medicines that otherwise, even paying a copayment, even a 5% or 10% copayment on that can be prohibited. So I know AARP is focused on this. How important is it for us to get a reasonable limit on the out-of-pocket costs?
Senator, it's very important. Access, as has been mentioned, is extremely important. We can have the greatest medicine in the world, but if people can't get access to it, how does it help? And, I know AARP testified recently in front of the Senate Finance Committee and made some of these same points. I think it's especially critical to point out about these specialty drugs you mentioned that commonly treat like cancer, rheumatoid arthritis, multiple sclerosis. They're probably some of the most expensive drugs on the market, but people can't live without them. On average, Medicare Part D enrollees take between 4 or 5 prescriptions a month, often for chronic conditions that they have to take this medicine for the rest of their life. At the same time, Medicaid recipients have an annual median income of just under $30,000. So this population doesn't have the resources to really absorb these escalating costs. And that's why we're behind these legislation that's in Congress and that you're supporting. Found that the average cost of some of these prescription drugs is $84,000 a year. And if we had some of these controls in place that are in the bill, the increase over the last 10 years would have been half of that. So we think steps need to be taken to bring costs down. And this bill is probably a good way to do it. But I like the cap you mentioned. I think that's an important way to go.
And as we look at the biologics industries, as we look at the new drugs that are coming on board, some are extremely, extremely expensive. We know Alzheimer's and the drug that's on the market there at the expense of that drug. And we're looking for ways of taking it out of the mainstream reimbursement system because they are such a large cost issue. And could very well be a breakthrough on dealing with Alzheimer's or other types of diseases. So we are looking for different ways to be able to afford some of these medicines. One thing is clear, the federal government will continue to be a leader in innovation. So we're going to continue to lead the world. And we can do that with the pharmaceutical industry making a reasonable profit. They don't have to make so much off American consumers versus the global marketplace. I want to deal with one of my pet peeves, if I might, and that is shortages of drugs in America. In America, that pays the highest amount of prescription medicines by far than any place in the world, the wealthiest nation in the world. We're paying the money, and yet we sometimes cannot get essential medicines here in the United States of America. Now, one might think these are expensive drugs that we can't get. It's just the opposite. These are inexpensive drugs we cannot get because they're usually single sourced, that is, only one manufacturer. Secondly, they are inexpensive, so the profit margins to the manufacturer is not as high as some of the more expensive drugs. So therefore, with capacity issues, they choose to manufacture the drugs that they can make more money off of rather than those that are needed. This is true with a lot of the injectables. We know that. It was true for a while with the drops that are put on a new baby's eyes in order to prevent infection. It was true in regards to bladder cancer with BCG treatments. So it's been true in several areas that drugs that are relatively inexpensive to manufacture are in short supply in America because of the profit margins to the pharmaceutical industry on a single source location. We got to do something about it, and I've introduced legislation to do something about it. But I really want to get all three of your attentions on this issue. I raised it at just about every hearing of our committee. I don't want to see drug shortages in America. We got to make sure that we have supply chains for essential products in this country. We've talked about that in regards to the coronavirus. We've talked about that in regards to supply chains from China and Russia. Let's make sure that we take care of having the drugs that are needed here in America for Americans. If any of you want to respond, fine, but I just really want you to be aware of this issue. Dr. Onukwugha, this is an area, again, that usually affects the underserved community more than the general community.
Absolutely. And it's one that I liken to when we think about these price increases that we've talked about with insulin and other medications, and some of the strategies that some states have looked at, which is really asking and collaborating with stakeholders to require advance notice when price hikes are planned or coming down the pike, or to foster justification of such price increases, discussion, and most of all, transparency. And it's a similar issue here where a lot of times the shortages come and there's very little preparation or prior discussion, even on the patient side, much less, to be able to talk about options. What alternatives do I have? How do I plan for them? So this information gap continues, and the costs as well, as you mentioned, are disparate. And I think it's thinking about ways to, while this might be unforeseen from our perspective, is it unforeseen across the board? And might there be gains to bringing more transparency to when you expect this to happen, engaging the right stakeholders so that the impact on the patients is minimized?
We only have a few minutes left, and I'm sure there are people who need help on prescription medicines. Can any of you give advice to individuals who, under the current system, are having a challenge paying for their medicines? What avenues are available to help them in order to be able to afford the drugs that they're taking?
In Maryland, we have the Maryland Senior Prescription Drug Assistance Program for Maryland residents who are Medicare eligible. So they might want to contact the state health department. That was passed by the Maryland General Assembly. You remember them a few years ago?
Yes.
So it's a good program right now for moderate income Maryland residents. the Maryland Senior Prescription Drug Program. There's a bill in Annapolis this year, Senate Bill 353, that puts a cap on insulin cost for commercial, like Blue Cross Blue Shield coverage. The government part is separate, but there's a bill in Annapolis to do that. And then we've been, AARP has been active with Healthcare for All and putting a prescription drug affordability board in effect to kind of look at cost and try to control cost over the long term.
We thank you
Just-
for that.
And I would say another area that I would imagine is going to be a growing population are individuals who have maybe due to language or culture, difficulty navigating the healthcare system, to be able to identify where these social services or healthcare services, such as available from MDH, can plug in to help them. And there are a lot of groups throughout Maryland that I've gotten to know that their full focus is on plugging individuals into the healthcare system so they can at least be aware and educated about some of these resources. And their focus is on immigrant populations and racial and ethnic minorities.
So let me just give an update of where we are in regards to consideration in Congress. And thank you all for pointing out what's available today. And of course, obviously, the Maryland General Assembly is in the last part of their legislative session, so we'll see what comes out. Maryland has been very progressive in its healthcare system. I brag all the time about our all-payer model and how that's been used to not only bring down costs, but to increase access to care, led by our hospital community, but now a lot broader than that. So I'm not surprised to hear that the Maryland General Assembly is taking steps to try to deal with the challenges we have in regards to rising prices. Prescription medicines were expensive before we started this inflationary pressure that we have today. But now with these inflationary pressures, it's even more challenging for individuals to be able to afford their prescription medicine. So we all need to take steps to do everything we can to help. In the Congress, we anticipate bringing to the floor of the United States Senate legislation similar to what I've talked about, competitive negotiating prices, discounts, rebates for inflation, caps on out-of-pocket costs, and limits on certain drugs can be charged. All that, I think, is going to be brought to the floor. We hope to do this with bipartisan support. That's certainly the best way for us to proceed. And as I indicated earlier in the show, the original foundation for the legislation we were talking about was legislation introduced by Senator Wyden and Grassley, a Democrat and Republican. So we hope that we'll be able to bring those issues to the floor of the Senate in a timely way so we can act on it in this Congress. So we know there's a challenge. I'm not naive about the special interests that are out there. We haven't talked much about it, but there are special interests that are protecting the pharmaceutical manufacturers and the pharmaceutical benefit managers. So we do have challenges in trying to get legislation to the finish line. But I can tell you, we've been working on this for a long time. The American public really needs Congress to deal with the cost of prescription drugs. And by the way, we also need to deal with the cost of childcare. We need to deal with the cost of housing. We need to deal with the cost of energy. These are all areas as a result of inflation that are making it more challenging for American families today. I want to thank my three guests for joining me today. Dr. Ebere Onukwugha, from the University of Maryland School of Pharmacy, Dr. Mariana Socal from the Johns Hopkins Bloomberg School of Public Health, and President Jim Campbell, President of the AARP Maryland Chapter and a former member of the House of Delegates. I've enjoyed our conversation. I really do think you have brought us focused on what we can do to lower the cost of prescription medicines, but you put it in context to a lot of other issues that we need to deal with to make sure we have access for all communities to the technology and healthcare that's available in this country. And I want to thank all of you for joining me today on Facebook Live. We'll continue this series on another timely subject. And again, thanks for viewing, and thank you to our guests.